Mastering the sideline throw-in is an essential aspect of a soccer game. The sideline throw-in is a critical maneuver in soccer for two main reasons. It gives a team a chance to take advantage of a turnover, and it offers a chance for the defending team to take back the possession of the ball. We'll be breaking down the muscular actions that are occurring in order to effectively move the bones with respect to the joints where they attach. To help provide a more concise description of the entire sideline throw-in maneuver, we have broken it down into 5 different phases: the stance, the preparatory, the movement, the follow-through, and the recovery. During the stance phase, the athlete is at his most comfortable and balanced part of the maneuver. During the preparatory phase, the athlete's goal is to effectively wind up in order to prepare the muscles that will be executing the movement. In the prep phase, the muscles are lengthening in order to provide an explosive contraction for the movement phase. The movement phase is commonly known as the action phase, wherein the summation of force gathered in the prep phase is applied to the support object, in our case it is a soccer ball. The follow-through phase, which begins immediately after the movement phase, is commonly known as the deceleration phase, wherein the muscles undergo eccentric contractions in order to slow the entire body's momentum. During the recovery phase, the athlete works to regain balance so that he's more readily prepared for the next athletic movement that is required of him. Overall, the sideline throw-in is a full body maneuver which requires many different muscle groups working together to help complete the sport skill. As you can see from the chart shown, there are many different muscles and joints that are involved in producing an effective sideline throw-in.
During the stance phase, the athlete is contracting all muscles isometrically, so he has set joint angles and is comfortably balanced. The joints being used during this phase are the radio-ulnar, humeral-ulnar, the MCP, PIP, DIP, and IP of the hand, the lumbosacral, acetabulofemoral, patellofemoral, talocrural, and MTP, DIP, PIP, and the IP joint of the foot. Of all the joints and muscles in use, everything is symmetrical except for the talocrural joint, where the left foot is dorsiflexing and the right foot is plantar flexing. In the radio-ulnar joint, we are using the wrist pronators to keep hands stable while holding the ball firmly in place. In the humeral ulnar joint, the athlete is using the elbow flexors to keep the soccer ball at mid-level in relation to the body in order to help prepare for the next phase. In the MCP, PIP, DIP, and IP joint, finger flexors are used to complete the action of flexion to grip the ball tightly. In lumbar sacral joint, the athlete is using lumbar extensors as well as trunk flexors to stabilize the athlete and help promote balance. In the patellofemoral joint, the knee flexors are being used to stabilize the athlete in the standing position and maintain a balanced position. And in the talocrural joint, the left dorsiflexors and the right plantar flexors are engaged so that they will help promote maximal balance for the athlete at the ankle. In the MCP, DIP, PIP, and IP joint, the toe flexors are also being used for helping to press into the ground to promote balance.
During the prep phase, the athlete is mostly contracting all muscles eccentrically to gain maximal power in preparation for the movement phase. His movements of the upper extremities are all symmetrical, however the lower extremities differ between right and left. The following joints are used during prep: scapulothoracic, glenohumeral, humeral ulnar, radio ulnar, MCP, PIP, DIP, and IP of the hand, lumbosacral, acetabulofemoral, patellofemoral, talocrural, MTP, DIP, PIP, and IP of the foot. As the athlete is raising the ball over his head, his ST retractors are performing retraction, his ST elevators are performing elevation, and ST upward rotators are performing upward rotation. These contractions are all occurring concentrically at the right and left scapulothoracic joints. His shoulder extensors are performing flexion, shoulder horizontal adductors are performing shoulder horizontal abduction, and shoulder adductors are performing abduction. These contractions are occurring symmetrically and eccentrically at the glenohumeral joint. The elbow extensors are performing right and left flexion eccentrically at the humeral-ulnar joint. At the right and left radial-ulnar joints, his radial deviators are working to eccentrically perform ulnar deviation in order to load the muscles for a more powerful throw. At the right and left MCP, PIP, DIP, and IP joints, finger flexors are performing isometric flexion to hold the ball in place. The trunk flexors are working eccentrically to perform lumbosacral extension to prepare for a more powerful movement phase. Alternating walking motions are occurring at the acetabular-femoral joint, where his hip flexors are concentrically performing flexion and the hip extensors are concentrically performing extension, alternating at the right and left legs. The athlete's knee flexors are concentrically performing flexion and the knee extensors are concentrically performing extension, alternating at the right and left patellofemoral joints in a walking motion. At the talocrural joint, the athlete's left plantar flexors are performing dorsiflexion eccentrically, while the right plantar flexors are performing plantar flexion concentrically. At the MTP, DIP, PIP, and IP joints, the left toe flexors are performing flexion isometrically, and the right toe extensors are performing extension concentrically to promote balance. During the movement phase, the athlete is concentrically contracting his muscles and applying force in the direction of the desired movement. All of the athlete's movements of the upper extremities are symmetrical, however the lower extremities differ between right and left. The following joints are used during this phase: scapulothoracic, glenohumeral, humeral-ulnar, radial-ulnar, MCP, PIP, DIP, and IP of the hand, lumbosacral, acetabular-femoral, patellofemoral, and talocrural. As the athlete begins to throw the ball, his ST protractors are performing protraction concentrically at the right and left scapulothoracic joints. His shoulder extensors are concentrically performing extension, and his shoulder horizontal adductors are concentrically performing horizontal adduction at the right and left glenohumeral joints. The athlete's elbow extensors are performing right and left extension concentrically at the humeral-ulnar joint to extend the arm further during the throw. At the right and left radial-ulnar joints, his ulnar deviators are working to concentrically perform ulnar deviation in order to allow for the release of the ball. At the right and left MCP, PIP, DIP, and IP joints, finger flexors are performing concentric flexion to keep the ball stable. The lumbar flexors are working concentrically to perform lumbosacral flexion to add greater force into the movement. The athlete's left hip flexors are contracting concentrically to perform flexion, and his right hip extensors are contracting eccentrically to perform extension at the acetabular-femoral joints. At the left patellofemoral joint, the knee extensors are concentrically performing extension. At the talocrural joint, the athlete's left plantar flexors are performing plantar flexion concentrically, while the right dorsiflexors are performing dorsiflexion concentrically to aid in stability.
In the follow-through phase, the athlete mainly is contracting the muscles in an eccentric manner. The joints being used during this phase are the scapulothoracic, glenohumeral, radial-ulnar, MCP, lumbosacral, acetobufemoral, and talocrural. The scapulothoracic joint on both sides will be doing protraction, depression, and downward rotation to help slow the arms down. In the glenohumeral joint, the athlete is using their shoulder extensors, shoulder horizontal abductors, and shoulder external rotators eccentrically. Eccentric pronation occurs at the radial-ulnar joint to return the forearms to an appropriate position to begin running. In the MCP joints, concentric abduction is occurring due to the flexor pollicis brevis muscles. In the lumbosacral joint, flexors are working eccentrically to help slow the body's momentum down from thrusting forward. In the acetobulofemoral joint, hip flexors are working concentrically. The left patellofemoral joint is being slightly flexed concentrically, and the right knee joint is extending concentrically. This allows the athlete to push off the ground and begin running. Isometric plantar flexion is seen in the talocrural joint as well.
During the recovery phase, the joints being used are the scapulothoracic, glenohumeral, humeral-ulnar, lumbosacral, acetabellofemoral, patellofemoral, and talocrural joint. A majority of the muscles are concentrically contracting in order to regain balance. In the scapulothoracic joint, the shoulder joints are concentrically contracting on both sides to perform the action of retraction. In the glenohumeral joint, the arm is performing a swinging motion as when an athlete does when they are running to get back on the field. In this motion, the actions being performed are both flexion and extension eccentrically. The muscles performing extension are the shoulder flexors, while the muscles performing flexion are the shoulder extensors. The left and right sides are opposite of each other and switch with each stride. In the humeral-ulnar joint, the elbow flexors are flexing isometrically, which is the same for both sides. In the lumbosacral joint, there is a repetitive twisting motion with each running stride. This is due to the lumbar rotators causing rotation eccentrically. In the acetabellofemoral joint, during the running motion, the actions being performed are both flexion and extension concentrically. The hip extensors are performing flexion, while the hip flexors are performing extension. The actions are opposite on each side and alternate with each stride. In the patellofemoral joint, the actions being performed again are extension and flexion concentrically, with the knee extensors performing extension and the knee flexors performing flexion. This is also opposite between the left sides and alternates with each step. In the talocrural joint, the action being performed is plantar flexion concentrically, which is caused by the plantar flexors.
For the majority of the sideline throw-in maneuver, the athlete is moving in the sagittal plane along the frontal axis. It is not until the recovery phase that the athlete begins to move within the transverse plane of the longitudinal axis at the pelvis and spine as the athlete twists during the running portion of the phase. The proper execution of all phases is essential for producing the most effective throw-in.